Chapter 48, Nursing Care of the Patient with Central Nervous System Disorders lecture. You need to make sure you know the key terms, the bolded terms, and the italicized words all through this entire chapter. You need to make sure you understand the terminology. This chapter talks a lot about the central nervous system. The central nervous system is the brain and the spinal cord. So all of this disorders that it's talking about are going to be with the actual brain or the spinal cord. The first one it talks about is meningitis. Meningitis is the inflammation of meninges that surrounds the brain and the spinal cord. It's either a bacterial or a viral infection. Your book tells you about the most common types of bacteria that are the cause of the bacterial, and then obviously if it's bacterial it can be treated. If it's a viral meningitis, we are not able to treat that. We just treat the symptoms. There is vaccines that are available against some of the pathogens that we have available. As an infant, there's the Hib vaccination that we usually start at infancy. And then as you are after the age of 65 or older, there is the pneumonia shot that we give as well. The CDC recommends 2 doses of the meningococcal vaccine for adolescents, one at about age 11 or 12, and then you get another booster about the age of 16. And then also they recommend college fresh students be vaccinated, especially those living in dormitories, because they're in that such close environment. If anyone has been exposed and had a significant exposure to someone that has been infected with meningitis, then obviously we want to do prophylactic treatment for those. One of the most common symptoms that we see with meningitis is a severe headache. And so we have to be very careful when somebody has a severe headache that we don't mistake that for an actual migraine. And one of the things that we're looking at to differentiate, is it a migraine or is it meningitis, is we're looking at the Kernan and the Brudzinski signs. If they have positive Kernan and Brudzinski signs, then often we see patients, then we know they have meningitis. Both signs are caused by inflammation in the meninges and the spinal nerve roots. And in order to check to see if they have the Kernan sign, the examiner is going to flex the patient's hip to a 90 degrees and then tries to extend the patient's knee. The sign is positive if the patient experiences pain and spasm in the hamstring. The Brudzinski sign is positive when flexion of the patient's neck causes the hips and knees to flex. So if you have either one of those positive signs, then we know that that patient has meningitis. Encephalopathy is when mental status changes are seen with patients with meningitis. They become very disoriented, they can't follow commands, they have a tendency to misinterpret their environmental stimuli. If they have encephalopathy and they have the late signs of meningitis, then we see that they have lethargy and seizures. Most likely it's going to be partial seizures, and at that point we're going to see that lip smacking or chewing. So they're constantly going to be smacking their lips or constantly like they're chewing their cud, basically. Complications from meningitis, if we don't try to get treatment, then their disease can be exacerbated and get a lot worse. But most likely once we realize that they have it, the good thing about viral meningitis, if you're going to have meningitis, it's the kind you want. It doesn't have any lasting effects. Bacterial meningitis can be fatal, so we want to be able to treat it quickly. Usually, if we can go ahead and treat bacterial meningitis, they can have full recovery. Diagnostic test, the best test that we have for that is a lumbar puncture, we're able then to look at the cerebral spinal fluid, and if we see white blood cells or see the bacteria in there, then obviously we know that we have bacterial meningitis. Obviously, I mentioned that the treatment was antibiotics. A lot of times we use the vancomycin and cephalosporins for the bacterial meningitis, and like I said, for the viral meningitis, we're just going to kind of treat symptoms at that point. Your textbook on 1002 has table 48.3. That's a very good summary of meningitis. If you want to look there quickly to see exactly what your signs and symptoms are, your diagnostic test, your therapeutic measures, your complications, and your nursing diagnoses. Encephalitis is an inflammation of the brain tissue. Viruses is the most common cause of encephalitis. And encephalitis is we see that sometimes with the West Nile virus that's carried by ticks and mosquitoes. There's other viral infections that can cause encephalitis, and that might be like mono and then the mumps. So it's very important that if you have a patient that comes in and you think you might have encephalitis, is to ask that patient, have they been on a camping trip? Have they been outdoors, to see if they've been exposed to ticks or mosquitoes? Common symptoms are headache, general malaise, nausea, vomiting, and fever that develop over a period of several days. Additional symptoms might be nuchal rigidity, confusion, decreased level of consciousness, seizures, photophobia, so that they're having trouble with the lights, it hurts their eyes, ataxia, which is lack of muscle control, abnormal sleeping patterns, and tremors. They may also have hemiparesis, which is weakness on one side of the body. The patient with herpes encephalitis, which is a type, if the patient doesn't have, if they have encephalitis and they've not gotten it from an insect borne virus, then usually it's the herpes simplex virus that's caused it. And this herpes simplex virus is the same virus that causes cold sores, and a lot of times stress can cause that virus to become active. And if a patient has herpes encephalitis, they develop edema and necrosis, most commonly in the temporal lobes. And so those patients, we really have to watch for increased intracranial pressure. Complications, obviously, is cognitive disabilities, personality changes. We can see ongoing seizures. Blindness can even occur as well. Diagnostic test, obviously, we're going to do CT scans, MRIs, lumbar punctures, all to diagnose those encephalitises. There's no specific treatment if it's insect-borne encephalitis. So in other words, we're just going to be treating those symptoms. All right, increased intracranial pressure is the pressure exerted inside the cranial cavity by the different components. Normal intracranial pressure is 0 to 15 millimeters of mercury. And obviously, our intracranial pressure is going to fluctuate when normal physiological changes. So when we change our position, we cough or we sneeze, or we have arterial pulsations, your intracranial pressure can change slightly, okay? But whenever you start having significant intracranial pressure changes, we may see that with brain trauma, we may see that for brain tumors, intracranial hemorrhage. Signs and symptoms of increased intracranial pressure. Initially, you're just going to see some restlessness, irritability, decreased level of consciousness because our cerebral cortex function is impaired. If this patient is not intubated, they can start hyperventilating, which causes vasoconstriction as the body starts trying to compensate. Also, they may have diminished reactivity and dilation of their pupils, so their pupils might stop reacting to light over a little bit of time as that increased pressure begins to increase. And if we get to the point, that they have a lot of compression and their brain tissue exerts pressure on the opposite side of the brain, both pupils become fixed and dilated. Vital sign changes is a late indication of increasing intracranial pressure. We have the Cushing triad, which is a classic late sign of increased intracranial pressure. And when we say Cushing triad, remember is 3. So what we're looking at is bradycardia, irregular respirations, and arterial hypertension, which is when the systolic blood pressure is increasing, but your diastolic blood pressure stays about the same. If you start noticing that arterial hypertension, or you see that basically that systolic blood pressure elevating, but that diastolic is staying the same, we have to immediately respond to that and let the healthcare provider know, or the RN. By the time you start seeing all these symptoms, the intracranial pressure is usually very high, and interventions may not be successful. And then the patient would, of course, have death, actually. If you look on page 1005, look at box 48.1. The signs and symptoms of intracranial pressure. Make sure that you know what those signs and symptoms are. A headache obviously is usually some of our early symptoms. We see dilated pupil on the affected side, decreasing level of consciousness, rising temperature, the hemiparesis, and like I said, a late sign is that increasing systolic blood pressure. On the nursing care plan there on page 1005, make sure that you've read completely through that and have yourself very familiarized with this. So with an inflammatory neurologic disorder or any kind of brain infection or injury, you're going to see a temperature that is elevated. So therefore we want to assess their temperature every 4 hours, and then of course as needed. We also want to administer acetaminophen or aspirin as needed. Your book kind of alluded to this, maybe not necessarily worded just the same way, so you might want to make notes with of this next statement that I'm fixing to say. But like I said, with inflammatory neurologic disorders, you have an elevated temp is expected. So an elevated temp is expected. Pain is expected, especially a headache. So, obviously you've got that inflammation in the brain, so you're going to get that headache. The patient should be able to change positions independently. So, with this, they shouldn't be so out of it that they can't change their own positions. Increased confusion is a major concern and should be reported to the RN or the healthcare provider. So if you start noticing that the patient's level of consciousness, their confusion is increasing, make sure that you are aware of that and that you're reporting that. And you want to report it as soon as possible. On page 106, 107, this is where your nursing care plan has continued. Obviously, we want to assess that level of consciousness. Like I said, that's something that needs to be reported. Any change in that level of consciousness can indicate increased intracranial pressure and should be reported immediately. You need to monitor orientation, reorient as needed. You're going to observe your patient's ability to react to simple commands. So all that's under risk for acute confusion. Under self-care deficit, you want to provide all supplies and equipment necessary to carry out their ADLs. You want to have all the equipment assembled so that the patient can reserve their energy to perform their self-care, because you really want to continue to have your patient do as much for themselves as they can. Encourage your patient to perform activities at their own pace. They may need to have rest periods. They may need to they may not be able to do them as quickly as sometimes us nurses want them to do it. But we need to be patient with them and allow them to do as much for themselves as possible. Encourage your family to participate. We've learned that when the family is there, promoting that support and family interaction, that the patient's outcomes are typically a little better. When you're looking at nursing diagnosis of acute and chronic pain, you want to assess their pain on that 0 to 10 scale. You want the patient to be able to express, what their pain level is. Obviously, we want to monitor their vital signs and administer pain medication as necessary. With the level of consciousness, we don't want to give narcotic medications if we can avoid it. We want to give non-narcotic medications because they don't alter our level of consciousness. If we realize these non-narcotic medications are not effective, codeine is something that has very minimum effect on the level of consciousness, so that may be an alternative that we might use. You can also use all kinds of other measures to reduce intracranial pressure, because remember, if we do different measures that increase the intracranial pressure, obviously that's going to increase their pain. We also want to use alternative comfort measures, dim the lights, have a quiet environment, and position for comfort. As far as risk for injury, obviously we want to teach the patient to monitor their own position in their skin and to direct position changes. So give them some control over changing those positions. We also want to turn our patient and assess skin every 2 hours while they're in bed. Especially if you've got a patient that is not able to feel that pressure. As far as impaired physical mobility, we want to assess the degree of their mobility. We want to turn them again, what's it said, every 1 to 2 hours. If they've had surgery, maybe on the left side of their brain, we might not want to put them on that left side because of that surgery. But, you just want to use your nursing judgment as far as that go. Always put them in the correct body alignment position. Perform range of motion exercises, especially if they're bedbound. Risk for injury, and we're looking mainly at if they have increased intracranial pressure, we want to remove objects from patients' surroundings to prevent injury during a seizure. Because a lot of times people that have head injuries or diseases and that sort of thing, seizures are something that can occur. So we want to make sure that we keep them free from injury if a seizure occurs. We also, if we have them on seizure precautions or we think that could be a possibility, we want to make sure that we pad the side rails with a blanket or a foam so that they do not injure themselves if they were to have a seizure. On page 1009, that table 48.4 measures to prevent increased intracranial pressure. Look at the preventative measures. It does tell you the rationale, but things that we want to do specifically to prevent increased intracranial pressure is keeping the head of bed elevated at least 30 degrees. The only time you would do that any differently is if it's been contraindicated. Maybe there's a reason why they can't have that. Avoid flexing the neck. Keep the head and the neck at the midline position. You don't want to stretch it out or pull it down too much because all that increased intracranial pressure. You want to administer antiemetics and antitussives because you want to prevent vomiting and coughing. All of that increases that intracranial pressure. Administer stool softeners because straining for a bowel movement can increase intracranial pressure. We also want to minimize suctioning. If it's absolutely necessary, then we're going to give them extra oxygen in well first. Then we're going to limit that suction and passes to 1 or 2. We don't want to suction very much if we can avoid it. Avoid hip flexion. Hip flexion can increase intra-abdominal pain, increases intra-abdominal pain and thoracic pressure, which all increases intracranial pressure. Avoid unnecessary noise and startling the patient. All of that increases intracranial pressure. And spaced care activities provide rest between each disturbance. As because if we were to do all of our activities, care activities at one time, that would increase their intracranial pressure. Okay, headaches. Headaches is a common symptom of a neurological disorder. Some headaches are not really a serious pathological condition, but a headache could be a serious pathological problem. Your book talks about primary and secondary headaches, and so we're going to talk mainly about the migraine headaches. Migraine headaches are a lot of times a neurologic disorder that involves brain chemicals and neurological pathways. If you have a migraine headache, like I said, or you have a headache in general, we want to rule out and make sure that you don't have meningitis. And one way that we are going to do that is to see if you have the Burnitzky or the Kernin signs. If you don't have that, then most likely we can say it's probably a migraine headache. Migraine headaches tend to sometimes have what we call an aura, which is vision changes or tingling that come before you actually have the migraine headache itself. Migraine headaches are often hereditary, so there is a genetic connection there. Children who have one or both parents who experience migraines are more likely to experience them. So we want to be kind of finding out from the patient, do you have a family history of this? Is it a genetic relation? So those are all things that we want to make sure that we're trying to follow through and ask about. Medications that we use to treat migraine headaches, if they're acute migraine headaches, NSAIDs, which are your non-steroidal anti-inflammatory drugs, are one that we use. It's a vasoconstrictor. It's usually effective if we can take it within that first 30 to 60 minutes of a headache before that vessel wall becomes edematous. Triptans such as Imitrex and Zomig work on the serotonin receptor sites, and they have a vasoconstricting action as well. We don't really want to do narcotic medications like opioids because of their habit forming tendencies, and if we have to use those are our last resort. Your book talks about tension or muscle contraction headaches. A lot of times this is because our muscles have become very tight, and we say it's muscle tension because when you're stressed out, your muscles react and they become very tight, and that can cause us to have a headache as well. Cluster headaches are a lot of times like a stress type headache as well. They come in clusters. They can last several days to weeks, sometimes even months to years. Alcohol obviously can increase these episodes. Like I said, the patient will typically, the headache comes on very suddenly, and then they starts having throbbing or excruciating pain. How do we diagnose headaches? Obviously, we want to, it'll be based off the patient's history, their symptoms, MRI, CT, skull x-rays, there's lumbar puncture sometimes even to rule out other causes. The nursing process for the headache, the patient with a headache, they use a mnemonic called "What's Up?" And it's just gives us useful information regarding a headache. So W is where's the pain? Does it radiate to other areas? Does the headache consistently start in one place? The H is how does the headache feel? Is it throbbing, steady, band-like, dull? What qualities does it have? The A is aggravating or alleviating factors. Were there things that you maybe consume that causes you to have to make the headache worse, like caffeine, chocolate, red wine, that sort of thing. The T is the timing. Might help with the diagnosis. When does it typically occur? How long does it last? The S is ask the patient to rate the severity on a 0 to 10 scale. The U is just ask about other useful information. Do you have nausea with this? Are you vomiting? Do you have bloodshot eyes? The P is determine the patient's perception of the headache. Does it interfere with their regular life? If so, how does it interfere? And has there been a previous evaluation of headaches in the past? When we're looking at the nursing diagnoses and the planning of that, we're going to look at acute pain. Our expected outcome is the headache will be prevented or controlled, as evidenced by the patient saying they have no pain at perceptible pain rating. So there's some bullet points there. Make sure you know those bullet points. Assist the patient to identify or reduce or eliminate aggravating factors. Have them keep a headache diary. Record the time of day, what foods they've ate, what aggravating factors. Just have them describe the pain and any symptoms that may go along with that. Encourage the patient to use alleviating techniques such as warm and cold compresses, biofeedback, stress reduction. Teach the patient to use relaxation exercises. We do want to provide a dark and quiet room. This really does help, but it's not useful when we are determining our treatment options. This just mainly helps with the pain. But like I said, it really doesn't help when we're trying to determine how we need to treat this. Teach the patient about medications they may be given, appropriate dosage, expected action, side effects, consequences of misuse. And then also want to look for that genetic connection. So we want to ask this patient, do you have any family members that may have a history of headaches?